seems that I came to know that she has said no to the talk. Probably she will be absent. In that case, we'll start with our presentation. First will be differential diagnosis, diagnostic evaluation, then genetics which can predict the possible outcome of surgery, and then angle surgery. Susmita will talk on that, expert on that subject. And at the end, I'll talk about whatever surgical techniques we are currently doing and some improvement on that, which probably will be the future way to go. Now, when we talk about changing paradigms, the key word is changing. Change is the law of universe. There is nothing constant except the change. Change is inevitable, change is constant. Change brings better opportunities or more opportunities. But we should remember, as glaucoma surgeon, not all changes are welcome, not all changes are forward moving. In the history of glaucoma filtering surgery or glaucoma surgery in general, be it pediatric glaucoma or adult glaucoma, there are so many surgeries described in the past which is now in the history. We realize that some of the surgeries do not work very well or the outcome is not very adequate, and that we'll discuss. Now, when we talk about glaucoma or the changing concepts of glaucoma surgery in the children, it's about discussing past, present and future. Now, it is said that present is the daughter of the past and the mother of the future. It is imperative to know what has happened in order to understand what is happening and what is going to happen. We must keep in mind that our current sophistication in the management of primary congenital glaucoma will in a few short years be regarded as rather primitive and outdated. So, only by a knowledgeable understanding of the past will we come to know and appreciate from the present and may help create a base for the future. It is with this idea this present instruction course is conceptualized. We'll go some basic talks which will talk about diagnostic evaluation, differential diagnosis, and the mimickers of primary congenital glaucoma, and then genetics, and then the surgical aspects. I'll request, since Muralidhar, the first speaker, is yet to come, I'll request Dr. Devashish Chakraborty to start his talk. He will be talking on diagnostic evaluation in primary congenital glaucoma. Thank you, Devashish.
Good morning, everybody. Thank you, Dr. Mandal sir, for giving me this opportunity. So, I'll be speaking on the diagnostic evaluation of primary congenital glaucoma. So, to begin with, just a brief overview of primary congenital glaucoma. As we all know, it is the most common form of developmental glaucoma, and the basic etiology is isolated, non-syndromic maldevelopment of the trabecular meshwork with no other ocular anomaly to explain the high IOP. It's usually inherited in an autosomal recessive manner, but there are other modes of inheritance as well. Family history is seen in about 10 to 40% of cases. It is more common in consanguineous populations. Mutations in CYP1B1 gene have been reported, apart from other mutations as well. And the definitive treatment for this condition is surgery. So, the classification according to the age of onset, it can be neonatal or newborn onset when it is within 0 to 1 month, infantile onset between 1 to 24 months, and late onset or late recognized when it is more than 2 years. And it is important to understand that more severe the angle anomaly, the earlier is the presentation and the worse is the prognosis. Hence, the condition should be detected at the earliest stage and appropriate surgery should be employed. Now, clinical evaluation is extremely important for this condition because number one, prompt diagnosis of childhood glaucoma and appropriate treatment can minimize the degree of visual impairment. And number two, there are certain mimickers of this condition, primary congenital glaucoma. We have to eliminate this at the outset, and some of these conditions can actually be life-threatening for the child. While speaking on the diagnosis of primary congenital glaucoma, like in adults, we have to rely on the IOP. In children, only IOP alone is not the main thing, because IOP measurements in infants and young children, especially during examination under anesthesia, can potentially be affected by many factors like the type of anesthetic used, the time point at which the IOP is recorded, and so on. So in children in particular, apart from the intraocular pressure, we have to look for other signs of glaucoma like ocular enlargement, the presence of Hobbs striae, the increase in the cup disc ratio, and so on. The aims of evaluation are to confirm the diagnosis, to discriminate between primary and secondary developmental glaucoma, establish baseline parameters, to assess the severity and prognosis, to rule out any other ocular and systemic comorbidities, and in particular to rule out space occupying lesions like retinoblastoma, which can sometimes mimic primary congenital glaucoma. So in the history, first of all, we have to document the age of onset of symptoms, the classical symptoms like epiphora, photophobia, and blepharospasm, and as well as corneal haze and opacification. Rarely red eye mimicking conjunctivitis, PCG can present in this way. We have to document family history like parental consanguinity, presence of glaucoma in the siblings, gestational history like rubella, and delivery history, example use of forceps, because there can be signs which can mimic primary congenital glaucoma in these situations. Coming to the symptoms, the classical symptoms described in most Western textbooks is a classical triad of epiphora, photophobia, and blepharospasm, which is attributable to the IOP-induced corneal epithelial edema. However, in the Indian subcontinent, large eyeball size and hazy eyes from corneal edema may be the more common presenting features, and a rare presentation can be acute corneal height drops. So the vision has to be assessed according to age-appropriate methods. The key to the diagnosis of primary congenital glaucoma is examination under anesthesia, and we have to record the refraction, corneal findings, intraocular pressure, gonioscopy, ophthalmoscopy, and take the decision for surgery. In many conditions, the surgery is done along with the EUA. These are the requisites for EUA. So you have to use a pediatric speculum, calipers, tonometers, ophthalmoscope, retinoscope, direct gonio lens, and imaging like the B-scan. So regarding the choice of anesthetic agents, as we have discussed, the IOP is largely affected by the anesthetic agent. The degree of IOP lowering is unpredictable and depends on the agent chosen, the route of administration, the depth of anesthesia, and the starting intraocular pressure. All anesthetics and sedative agents lower the intraocular pressure except ketamine, chloral hydrate, and benzodiazepines. Sevoflurane is the most commonly used inhaled agent due to its convenience and safety profile, and it is very important that the IOP should be recorded the moment the child stops moving after inhaled anesthesia and prior to intubation. Regarding the tonometer, Perkins is a gold standard. Tonopen is also used, but it overestimates the IOP compared to Perkins in normal children and in those with glaucoma. Eye care is portable. It has a similar reliability to Tonopen, but the advantage is that it does not need topical anesthesia and can be used in the upright position. It's important that we use the same instrument on follow-up, and again to stress that the IOP should be measured as soon as possible after initiation of the inhalational anesthesia and prior to intubation. The corneal haze is representative of the severity. The greater the haze, the greater is the severity of the glaucoma. It's usually more in center, and we have to document what are the structures that are visible, like the pupillary margin, iris details, and fundus details. Initially, this edema is simple epithelial edema due to elevated IOP. Subsequently, there is permanent stromal edema. That is why we have to act early. Untreated, the edema progresses to stromal scarring and irregular corneal astigmatism. The corneal diameter should be measured. So the corneal enlargement secondary to elevated IOP usually occurs before 3 years, and it's a marker to establish the diagnosis and progression. The differential diagnosis of increased corneal diameter are megalocornea, connective tissue disorders, and congenital high myopia. We measure the horizontal visible corneal diameter from white to white. It's important to know some figures. The normal measurement is about 10 millimeter at birth. Abnormal values are more than 11 millimeter in newborn, more than 12 millimeter in a child less than 1 year of age, and more than 13 millimeter at any age. Corneal striae are almost pathognomonic. So hub striae are concentric to the limbus in periphery, and they're more typically horizontal centrally near or across the visual axis. The breaks in the Descemet's membrane due to forceps injury can sometimes mimic these lines, but these are vertical, unilateral, central, and the child has normal corneal diameter, and often they have periocular bruising due to the forceps injury. Gonioscopy, we know that the normal angle development occurs by the posterior sliding of the ciliary body from the Sholby line from the 5th month to the scleral spur, that's 5th month to the 9th month. And in the normal newborn eye, the iris has recessed beyond the scleral spur, so the scleral spur is visible only as a whitish band. But in contrast, in PCG, the iris insertion is higher, the peripheral iris inserts to the trabecular meshwork, and the scleral spur is not visualized. The optic disc and the fundus should be assessed. So in the optic disc, we have to note the cupping and the focal areas of rim loss. A cup disc ratio of more than 0.3 in an infant and more than 0.5 in an older child is suspicious. Striking reversal of cupping may result with IOP reduction after successful glaucoma surgery, unlike in adults. And in the retina, we should do an indirect ophthalmoscopy to rule out choroidal hemangioma, pigmentary retinopathy. So these are some of the other causes that can present as childhood glaucoma. So pachymetry is probably not as important as in adult glaucoma, but we know that it can influence the accuracy of the Goldman applanation tonometry. It can artificially overestimate or underestimate the true IOP, but the definitive role of pachymetry in the evaluation of childhood glaucoma is uncertain. So approximately it's 540 micrometer at 6 to 23 months, thinner in primary congenital glaucoma, thicker in aniridia and glaucoma following cataract surgery. The CGRN recommends that CCT should not be used to adjust an IOP measurement, but rather taken into consideration in the overall context. B-scan is an extremely useful tool when we do not have a proper view of the posterior segment. So it can detect marked disc cupping in the presence of opaque ocular media. It can also help us to exclude posterior segment pathology like retinoblastoma or choroidal hemangioma, and it helps us to diagnose and follow up postoperative complications like choroidal detachment and suprachoroidal hemorrhage. Also, increase in the axial length on sequential examination is a sensitive indicator of the progression of glaucoma. UBM, when it is available, can be used in certain situations. So we know UBM uses a frequency of about 50 megahertz with shorter wavelength and shallow penetration causing maximum resolution. It's useful for suspected retroidal pathology, example ciliary body masses. Also useful for assessing anterior segment in presence of corneal edema, corneal scar, dense cataract, etc. So to summarize, primary congenital glaucoma is the most common form of developmental glaucoma. It is isolated, non-syndromic maldevelopment of the trabecular meshwork with no other ocular anomaly. It's usually inherited in an autosomal recessive manner. In the history, we have to know the family history, any consanguineous marriage, and the age of onset of symptoms. The classical triad of symptoms, as we all know, in addition to the classical triad of symptoms, we have large eyes and hazy cornea. These are the more common symptoms in the Indian subcontinent. The diagnosis is mainly established by UA, so the IOP is measured by Perkins. We have to note the corneal diameter, corneal haze, hub striae, gonioscopy, disc cupping, and fundus. USG B-scan is a useful tool. We have to beware of mimickers, and I think Dr. Murli will take up this topic. And the key message is that prompt diagnosis and proper and prompt treatment can minimize the degree of visual impairment. Thank you. So these are all my key references.
Thank you, Devasis, for an excellent presentation on the topic. I am sure there will be some question which we'll discuss at the end of all presentation. Our next presenter is Dr. Muralidhar Ramappa. He will be speaking on mimickers of primary congenital glaucoma. Dr. Muralidhar is a senior member of our L.V. Prasad Eye Institute faculty team and head of rare eye diseases. He has been associated with the institute for more than 20 years. He did fellowship with L.V. Prasad Eye Institute, then in the faculty after that. Thank you, Murli.
Very good morning, sir. Thank you for kind introduction. Right. So, at outset, I would like to thank Dr. Mandal and AIOS for giving me this opportunity. And Debashish, in his presentation, he made my job very, very simple. So my role is to, what are all the various mimickers of primary congenital glaucoma, how do we unravel, and we'll have a systematic approach to differentiate each one of them. Do not have any relevant financial disclosure. So why do we have a corneal edema? Presence of any abnormal material, it could be fluid, inflammatory debris, or a metabolic end product can give rise to corneal opacification because it does affect the corneal architecture and the regularity. If you look at this busy slide, so each of these cornea, the cloudy cornea, have a different shades as you go from the left to right. And one of the very classic, if you look at a bluish white corneal discoloration, one can easily assess and also see the entire architecture of the globe is distorted. So pretty easy, simple when we compare everything, but in a day-to-day practice, we tend to encounter certain borderline scenario where it may be difficult to distinguish. So when you see any child with shades of gray, and definitely the 6 to 8 causes will flag. And these DDs are not just limited, there are additional, right from fetal alcohol syndrome, axonal Rieger anomaly, and as Debashish pointed out, including the posterior segment abnormality like FEVR or ROP can actually give rise to corneal cloudy. And I skip in the interest of the time, he has covered very elaboratively the detailed evaluation, including the detailed history, consanguinity, because in the southern India, consanguinity is more prevalent, hence, primary congenital glaucoma prevalence is much higher. And he also talked about, intraocular pressure assessment may be dicey in a certain scenario where we may have to rely on surrogate measures like a white-to-white diameter, axial length, anterior chamber depth, myopic shape, and so on. In addition to, the imaging, we do have a swept source imaging. I'm sure our next speaker, Professor Sushmita, will be elaborating on that. It is an invaluable tool when we don't have an access to UBM or a anesthesia facility. It can be done, in an OPD procedure. She would be detailing on the, the various techniques how we can acquire a pretty decent imaging in a child. So we'll start with the primary congenital glaucoma. As Debashish pointed out, they have a bluish corneal discoloration owing to presence of fluid in the corneal epithelium particularly. Unlike all other conditions, primary congenital glaucoma child will have an intense blepharospasm, photophobia, and lacrimation. That is a very classic triad. In addition, when we examine, not only the cornea is edematous, it is enlarged. There is a global enlargement owing to rise in intraocular pressure. We need to remember the pediatric eye is pliable in the first 3 years. It is amenable, it tends to distend with the rise in intraocular pressure. As it distends, there is also, stretching of the limbus and episcleral tissue, and like it gives a ophthalmic kind of a picture. At certain, when it crosses the physiological limit, DM can break and can give rise to HAP strain. And of course, intraocular pressure is rise, and we have to be factoring, so anesthesia, corneal edema, and so on before labeling it. So as I said, the white-to-white diameter, as he rightly said, in a newborn baby has a 10 millimeter, less than 10 millimeter. At 6 months, 10.5. At 1 year, 11. So these are all the normal white-to-white, visible white-to-white, diameter. Any aberrations which we have to take into consideration. One of the caveat is some of the microophthalmos or a microcornea, which also have a rise in intraocular pressure, so may have a normal corneal dimension. So one has to be carefully interpret such cases. So the next DD is congenital hereditary endothelial dystrophy. This is also autosomal recessive condition where you have a single gene, that SLC411 mutation, and it is also very prevalent in particularly southern India and also other Asian countries where parental consanguinity is very high. And CHED can actually have a varied spectrum. Some of these cases can have a mild innocuous disease where you can actually see the entire iris and a pupillary detail. It is not obscuring, including the decent retinoscopy and retinal view. So wherein we may not to do any intervention. As you go to the right, the severity increases, and these cases may benefit by doing endothelial keratoplasty. And lower panel showing this is a child who presented much later at the age of 16 years. Because of a chronic corneal edema, you could see a lot of secondary changes. The high resolution OCT also showing not only epithelial edema and also entire Bowman's anterior stroma is densely scarred. It has a degenerative panels. In such cases, we may have to resort to penetrating keratoplasty. Unlike PCG, if you look at carefully, there is no limbal stretching, horizontal white to white diameter is normal, and on a slit lamp when we evaluate, you don't see any epithelial bullous changes in a regular CHED, because even that suboptimal endothelium with the Descemet's membrane is still serving a very robust filter so that it doesn't manifest a corneal edema very early on. The next in line is posterior corneal dystrophy. This is a polymorphous dystrophy. You can see a beaten metal appearance. It's a very subtle. Mother of a child who was otherwise asymptomatic. It was an incidental finding. And grandfather has a much milder disease. Whereas the grandchildren, both of them have such a significant severe central warty corneal granularity. You can see here. And on an OCT, it can actually shows up. You have a sawtooth pattern, meaning it's not only endothelium is abnormal, they are metaplastic, they are multi-layered, and hence you have a sawtooth pattern that actually give rise to something called as a warty appearance. They generally have a vesicles, large vesicles. As the disease progresses, they coalesce to form a dense corneal opacification. And here distinctly this affects the central cornea. Peripheral cornea is relatively spared. Again, your limbus and other architecture are seemingly normal here, including intraocular pressure is normal. Again, in these cases, gonio is very, very important because this metaplastic layer which is proliferating on the corneal endothelium can extend onto the iris, can result in a secondary angle closure which is similar or analogous to what we see in a Heiss syndrome. Again, there are 4 distinct types of PPCD, and one of the PPCD where you have a call 8, so can also have a keratectasia. And generally they have 50% of them have a glaucoma. And since it is autosomal dominant, it's very, very important to examine parents as well. Third in category is a mucopolysaccharidosis, what we typically call lysosomal disorders. There are about 9 different types. And the type 2, that is a Hunter's, is the only one which doesn't involve the cornea, hence the transparency is not affected in the Hunter's. Again, it can manifest typically 6 months to 12, and you have a very clear-cut clinical signs. One cannot miss this when you examine a systemic feature. And they have again a very dense grayish corneal opacification. Hurler's is one of the most severe form. They tend to have a marked corneal opacification in comparison to the Mortax lami, which is much more common in Indian subcontinent. So they do have, in addition to normal intraocular operations to start with, they end up having a posterior segment abnormality that can irreversibly lead to the marked reduction in the vision. Also, it is always, we have to work in conjunction with a metabolic specialist and a pediatrician completely to unravel. Now, the good news is that if you detect very early on such children, we can send them for a hematopoietic stem cell transplantation. The child is under 2 years. Beyond 2 years, we can actually do something called as an enzyme replacement therapy. And some of these cases I have been following for the last 20 years. Those which had an enzyme replacement, they almost phenotypically look normal, healthy, children and adult, except, their cornea tend to, get opacified because cornea doesn't have a vascularity. So at this point in time, ERT doesn't help in reversing the corneal edema. And a very rare entity called as a congenital hereditary stromal dystrophy, unlike CHCD, here in a cornea is a normal in thickness. You can see a flaky white corneal opacification. It is again grayish white. I'll just take a couple of minutes, sir, with your permission. And intraocular pressure is normal. White to white diameter is seemingly okay. The pachymetry is around 450 to under 500 microns, where endothelium is normal here. In such cases, I do anterior lamellar keratoplasty. That gives rise to good outcome in such cases. Debashish has elaborated, although it is a rare condition, particularly in the Indian context, it is a much more prevalent. He talked about, Dr. Shubho will be, highlighting the genetics of it. I will not go into details of that. So we were talking about the classic clinical trial. So this is very, very important because, rest of the condition will not have this kind of, photophobia, lacrimation. That's easily can be detected. And the horizontal corneal diameter in the first 2 years is a marker of the disease. In our cohort, out of 2400, where Dr. Mandal has operated 1800 cases, only 12% of them had a persistent corneal edema that needed a corneal transplantation. As in this particular case, a newborn presented with a 60 was a pressure. If you look at all dimensions of eyeball, he is stretched, elongated. You also see a limbal stretching. And such cases can be systematically managed where we can take an intraocular pressure. This is one of the Mandal's case where following a trabeculectomy, the cornea is cleared. As I said, only 12% of the cases which have an infantile or intrauterine onset of PCG can have a corneal affliction. Otherwise, most of these cases, once you control intraocular pressure, the corneal edema reverses. And one other interesting thing what we've observed, so once you take care, if you have a robust IOP control, the cup tend to reverse. At this point in time, I don't have any data to show the fields also reverses. And there are many factors which are responsible for the poor outcome apart from a corneal edema. My threshold is a very high here. I do not operate unless the child has a significant visual morbidity, because PCG is a one nightmarish condition for a corneal specialist, because once you do corneal transplantation, although they don't lack a vascularity in the cornea, they tend to do well, but again intraocular pressure and a graft survival, they go hand in hand. And right from amblyopia, optic nerve head, eye astigmatism, they all can contribute to the poor outcome. So some of these cases systematically we can manage, end up having an extremely good outcome. So the key is good history and a detailed evaluation will help in unravel PCG from other mimickers. And we as an ophthalmologist and a glaucoma or a particularly cornea specialist play an important role in picking up some of the life-threatening metabolic conditions that need a prompt systemic evaluation, either by a molecular diagnostic facility or a metabolic specialist. It is always important to have those allied branches, so that helps in not only taking care of their vision and also the life of the child. And since many of them are, have a genetic origin, I think genetic counseling is very, very important. Maybe in a 2 to 3 generation, we should be able to eliminate if we really focus on such conditions. Thank you, Dr. Mandal, for
Thank you, Murli, for covering the topic in a very comprehensive way. We'll have a discussion at the end, as I told. Our next speaker is Dr. Subhabrata Chakravarti. He will be speaking on role of genetics in prognosticating of primary congenital glaucoma. Dr. Subhabrata is in the genetics department at the L.B. Prasad Eye Institute for more than 25 years. We have the world's largest series included in a large cohort of primary congenital glaucoma genetics. He will be talking on that. Thank you.
Thank you, Dr. Mandal, for that very generous introduction and also for the opportunity to speak here. So the topic that I was given is role of genetics in prognostication of primary congenital glaucoma. As you know that it is not only complex disease, but it also has a very multifactorial etiology that when I go through. Debashish and Murli have discussed in great detail about the phenotypes and how there could be overlaps, how there could be challenges in diagnosis. Now, what about prognosis? So, prior to that, yeah, there's the customary that I don't have any financial disclosures. So, for a patient, what we are looking into, we need to kind of link the genotype to the phenotype. So, an undiagnosed patient comes to your clinic, and we need a very structured phenotype. That means the phenotype of the patient has to be in a way that it falls under a specific diagnostic regime. Now, with the advent of genomic technologies, one could go in for identifying specific candidate genes, given that there are genotype-phenotype correlations for certain genes. In other cases, it becomes goes on a research mode in terms of clinical sequencing, in terms of sequencing of the exome or the whole genome, and the corresponding family members to generate the data on inheritance. The data is then shared, the genotypes are linked to the phenotype along with the data. In the background of course, the ethical considerations are there. But since we are doing, we are kind of undertaking whole exome or whole genome sequencing, additionally that needs to be validated in appropriate model systems. For instance, it could be an in vitro model where one actually introduces those variations seen in the genome in particular cells or primary cells or cell lines, or it could be in vivo models using a particular animal models. We don't have any specific animal models for glaucoma. What we do have is models for quantitative traits, like we have models for intraocular pressure, we have models for enlargement of the diameter and enlargement of the globe particularly, and so we try to kind of correlate those, and based on that one again comes to a particular diagnosis to see whether that kind of links to the genotype, and thereby whether that can change management. If there is a perfect genotype-phenotype correlation, whether that can change the practice pattern, that can change the management or the future planning, as Murli highlighted too. So in terms of from a clinical perspective, it is more of genetic testing, and as we know that there are two modalities of testing. One is the diagnostic testing, where one tries to establish a particular link between a genotype and a phenotype. The other is predictive testing. Now, in diseases like congenital glaucoma, where one is kind of establishing a diagnosis, we really don't go for predictive testing, because in these cases, the disease has already set in, it is congenital. Predictive testings are mainly done either for a pre-symptomatic condition where you have a family where the individual is symptomatic and hasn't developed the symptoms yet, or they are predisposed because they have a family history of the disease. In either of these cases, these are mainly the age-related conditions where this thing is kind of seen, and in terms of congenital glaucoma, it will be more of looking into the diagnostic modality. So currently there are multiple genes that have been identified in congenital glaucoma. As both of the earlier speakers said, that CYP1B1 or the cytochrome P450, which is an enzyme which has been linked to the disease, not necessarily it is causal for the disease, and that has a wide range of prevalence across different populations. And if you look into populations both from India and other places, there are populations which have higher prevalence of these variations in this gene, but not necessarily these are causal. And the other genes that were simultaneously mapped, like a solute transporter LTBP2 or an angiopoietin receptor TEC, you would see that in the Indian scenario, these have much lower penetrance, much lower prevalence, as well as much lower effects on causality. But what happens with the cytochrome P450, the reason that it was mapped is that there are certain signatures in cytochrome P450, and no matter from which population you come from, you harbor that signature. These signatures are basically, if you align those variants on a chromosome, on a single or a haploid chromosome, we get something called as a haplotype. So mutations are structured on these haplotypes, which means that if you have a mutation, let us say it's a glycine for glycine to a glutamic acid, and it's in patient in Ecuador, whether you are from Morocco, Saudi Arabia, or India, you will have you will harbor the same haplotype. Meaning thereby this, since evolution, since the migration of populations, these haplotypes have been constant. And so these are good for kind of understanding that they have a disease which is linked to this, but this does not necessarily mean that they would, they would conform to primary congenital glaucoma, because even in other conditions, even in individuals who are asymptomatic, you might find such kind of haplotypes. Now, what about genotype-phenotype correlations? So, for patients who are harboring those kind of changes, and if we look into the quantitative traits like intraocular pressure, corneal diameter, or cup-to-disc ratio over a period of time, and given that they are harboring 2 copies of the mutant allele or 1 copy of the mutant allele, or do not have any mutant copy, there is practically no relations with CYP1B1, and this is a data that we combined our data with the Brazilian data. It was over 950 patients from both the countries. And what we show is there is a minor involvement of poor prognosis only with homozygous CYP1B1 variations. But where we did find some kind of an evidence is a variant in the promoter region that regulates the functions of CYP1B1, and this region harbors a variant which is strongly associated with primary congenital glaucoma cases. Given that there is this variant, it will reduce the activity of CYP1B1, and CYP1B1 is required not only for development, but it actually converts retinoic acid, it regulates the retinoic acid signaling pathway, converts retinol, which is an alcohol, to an aldehyde, which is retinal, and in the absence of CYP1B1, the developmental process is impaired. So that's one of the clues that we have. And given that they have this variation, the reduction of CYP1B1 activity occurs to the tune of 90%, and there are other transcription factors which are involved in development, like the GATA1, PBX, etc., and their bindings are also impaired. But from a clinical perspective, now the children who are harboring this, and if you are following them up for an year, the child who harbors this variant, they also have corresponding variants in the coding region. That is why they have a haplotype. And if you see that in terms of their prognosis, in terms of their IOP control, they have poor IOP control compared to those who do not harbor those variations. So that's one of the only indications in CYP1B1 that if one looks into mutations in the coding region, that has to be in consonance with the promoter variant. So other than that, we now have ClinGen, which is another organization as per the NIH's directive to kind of integrate all this data, genomic and health data, for improving genomic medicine. So the variants that are observed are obviously, they are characterized on the basis of multiple other parameters, on the basis of screening of controls. And in the glaucoma variant curation panel, those of us who kind of are involved in this, what we try to do is to see that if there are variants that are uploaded, how many of them would actually have a clinical implication to show the impact of those variant on the phenotype. And that is the database that we kind of manage. And what we have shown is that even for changes which leads to the truncation of the protein, there are certain parameters which have now been improvised, and it's not only the presence of the variations, but it is also the function of those variants. Do they actually regulate the function? Is there a reduction of function? And so on and so forth. So if one goes in to identify those under a process of genetic testing, what we find that for the candidate genes, there will be around 20 to 30% of the variants. So if you concentrate on the purple part, a larger part of the section will be unknown. If we target other genes, for instance, in the anterior segment and all other developmental genes along with the glaucoma-associated genes, that number of unknowns might reduce by 10% when we do whole exomes. It might reduce further, but doesn't necessarily take away the entire thing. That is because there are a lot of co-occurring alleles, which means that variant of one gene co-occurring with another gene, and they are functionally regulated. And this is not only true for glaucoma, even in retinal diseases, for instance. If we scan the entire genome, you see that around 30%, here it is around 32%, of the variants are always unknown. So when we undertake these functional assessments, what we see is if there are multiple variant of one gene coming from father, another from the mother, they are asymptomatic, but child inheriting both in a digenic fashion or in a multi-allelic fashion, they manifest the phenotype. We go on to assess their function and see how that impacts the protein function. So just if you could see that CYP1B1 interacts with TEC, and by themselves they interact, but if there is a mutation, the mutation perturbs that interaction. The interaction comes down, and that is why the functions are perturbed. And in case of in case of the variant itself, like CYP1B1, like the heterozygous CYP1B1 variant, for instance, they do not interact and they do not impair any functional assessment. Likewise, there are other genes like serine protease, etc., where if you knock out those genes, they also interact with CYP1B1. If you knock out those genes in the animal models, like in the mice models, for instance, if you see the trabecular meshwork, you follow them over a period of time, the trabecular meshwork becomes hypoplastic as opposed to the normal one. And likewise in GLIS, which is another cripple transcription factor, if you follow them, if you knock out those genes because they interact with CYP1B1, the trabecular meshwork becomes hypoplastic. But how are we going now that we have this new data? How do we then take on genotype-phenotype correlations? So we used the photopic negative responses of these kids and compared to their fathers, compared to their parents. And what we find is that given that they have multiple variants, the photopic negative response in the child over a period of time is diminished. And if we quantitatively look into those, for instance, those who harbor those multiple variants, you see a stronger correlations of the clinical parameters in terms of their corneal diameter to the photopic negative response, in terms of their intraocular pressure control to various parameters of photopic negative response, as opposed to if you see on this panel that there are no changes, there are very minimal correlations for those who do not harbor those variants. Again, meaning bringing the fact that we need to see it on a multi-allelic scale and then try to kind of correlate the genotype with the phenotype. So there are different models, different pathways that we have proposed. One is the developmental pathway, the cellular death pathway contributing to PCG, and these are again individually contributed by individual gene variants from different genes and different pathways that interact together. One of the last things that I want to stress upon is, actually I have a talk again at 11:30, and some of the slides will be there as well, where we use multiomics to kind of characterize the disease. And what we have shown is that the presence of controls, a very deeply phenotyped controls, is essential for understanding the disease phenotype, because these interactions also occurs in the normal individuals. There might be modifiers, but that needs to be eliminated. For instance, if we take the 1000 genome data or the GenoMat data, which is normally done by many service providers, what happens is, like, we have longitudinal cohort data where for across all the glaucoma and the anterior segment disease genes, we found that there are close to 400 rare variants which are causal, of which 143 are present in the general population. And these are deeply phenotyped since they are followed up over 3 times in 15 to 20 years. Now, if you see the distribution of those variants in the 1000 genome and other global databases, there are only 28 in Punjabis of Lahore, 28 again in Gujaratis of Houston. In Telugus, they have only around 13. Among the Sri Lankan Tamils, around 32. among the Bengalis around 23. So if you take the representative of the population, there are so many less variants in the general population in the global databases. So that will render your data to be false positive. Why? Because we see that in the general population, we have 143 if you take a local cohort. But if you use the global databases, if these variants are outside this 23 or 24 variants, every other variant will be considered as normal. So that is where one needs to be kind of cognizant and vigilant about these facts. So the key takeaways are that it is a complex disease. It is becoming complex. It used to be a Mendelian disease. But now we know that it is attributable to multiple gene variants with varying magnitudes of effect. And with a multifactorial etiology, the dissections would involve considerations of the multi-omic components. I'll be discussing that in the 11:30 session, so I'm not much of it. Genetic testing components are still varied, and universal signatures are still being studied. So just given that they have a CYP1B1 mutation may not always render them to be having PCG. There could be other conditions as well. Large effect alleles sometimes exhibit associations like we kind of find out sometimes, but they may be inconclusive for a genetic diagnosis. And as of now, even clinical diagnosis holds the key towards prognostication as the biological components for all these quantitative traits are unearthed. So I'd like to thank all the patients and volunteers. All the patients almost are from him, and the team at my end, and the collaborators and funding agencies. Thank you.
Thank you. Thank you, Subho, for extensive presentation on this topic. Our next speaker will be Susmita Kaushik. She will be speaking on ab interno angle surgery. Susmita did his post-graduation from Maulana Azad, then did fellowship in PGI Chandigarh, continuing in faculty for about more than 25 years. Yeah, thank you. Carry on.
Thank you, Dr. Mandal, and thank you, APAO. Just to, the disclaimer is that we've taken informed consent because I show the babies who are identifiable to put the talk in context. So we who deal with children realize that we are not dealing with just pressure. This is one glaucoma where vision and the entire lifetime is important. And as much as we may like to think so, sometimes trabeculectomy could be a ticking bomb in these babies. So, and if you put in tubes, you put an even bigger bomb. So everybody so when people say that I put in tubes extensively and it's fine, the answer that all us white-haired people say is just wait a little bit and you'll know what fine is. So the idea of ab interno surgery, just as in all MIGS, is a minimal disruption of the conjunctiva, sclera and iris. And the angle-based surgery's idea is to bypass abnormal trabecular meshwork, assuming that we are dealing with primary congenital glaucoma, but it doesn't preclude further surgery. It's like saying this is step 1, but you might have a step 2 or step 3 depending on that, but if the step 1 works, we'll bypass the rest. Now, before we go on to angle surgery, it's important to understand that in primary congenital glaucoma, the angle doesn't recede normally, which means that the iris remnants persist, and the characteristic of that on gonioscopy is a high iris insertion, and the trabecular meshwork is functionally abnormal. So this on the left is a normal infantile angle, a very sinuous trabecular meshwork visible. This is a type 1. Now this type 1 and type 2 are given to us by Sampaolisi in the 1960s, and he actually recognized that the angles which are type 1, you have some TM visible with iris remnants, and these are the ones which are more amenable to angle surgery. Whereas if you have a type 2 angle where the trabecular meshwork is completely obscured by the iris remnant, the angle surgery is likely to be less successful. But that's something to keep in mind, and the importance of gonioscopy before doing angle surgery. So goniotomy, rather, I love this video, and I use it in all my MIGs because I tell them that it's the mother of all MIGs, and it actually all started in the babies. So it's just sliced, and that white thing that you see behind is the posterior part of the Schlem's canal, and the iris just falls back and the cleft is formed, and that usually is enough to take care of the outflow. So this is an angle with the iris remnants up, you can see, and once the trabecular meshwork is incised, the whole thing just falls back and it forms a cleft through which the aqueous is able to now get out. So this is the cleft that we form. What happens is the iris just falls back when you incise it because it's elastic. The question is it universally effective? Well, high success of goniotomy has always been published in Western literature, and overall success of 88% after one or more goniotomies. It's widely believed to be less effective in Southeast Asia and the Middle East because of the early age of onset and more familial cases and poor corneal clarity. But then we don't always have familial cases, we don't always have bad corneal clarity, and we don't always have a neonatal onset. So what about those children? Do we just give it up and say it doesn't work? So when you ask a lot of questions, you decide to give the answers and then share what you found. So we did goniotomy in children that we could and said, okay, let's take it as it comes, and if we can't, and if it doesn't work, we can always go in and do the second surgery. We had success rates of almost 80% of one primary surgery, and we had 68% for a redo surgery. Redo surgeries were those in which a combined trab with trab was done, where the corneas had cleared a little bit, but you still wanted a little more of IOP reduction. And if we did 2 goniotomies, then the success went up to 90%. So it was pretty much as was published for years and years from the West. It's been an encouraging journey so far. So this is the garden variety of infantile PCG. When I see this PCG, I'm happy, because then I know that I can do goniotomy, and a couple of years and maybe many years down the line, these babies are going to do all right. This is the kind of infantile PCG where we do 2 goniotomies. They come absolutely hazy like this, and sometimes even with this haze you can manage to do a goniotomy, but you can see from here it clears this much but not as much as you'd like. So we used to just go in from the nasal side and also incise the temporal part, and you can see how the corneas had cleared. So it was an encouraging journey, but the next question, so you keep questioning yourself, can you do better? Can you do better than 90%? And then came in BANG. BANG is bent angle needle goniectomy, which Shute proposed that instead of incising trabecular meshwork in adults, why don't we just excise it? So the KTB is of the same principle, and BANG is when you make a little bit of an angle in a 25 gauge needle and you strip the trabecular meshwork. It's a variation of the technique. So this is what it looks like. You'd see this 25 gauge needle and you just bend it in a reverse cystotome so that the smooth part is outside, so that you don't damage the Schlemm's canal, as it were. And then you just go in the normal way. This is in a PCG child. You go in and this is a cohesive viscoelastic on the surface. This is the needle going in, and you just engage the trabecular meshwork, and as you slowly strip it, in a minute you'll see the bit of trabecular meshwork which is on the tip of the needle. So you have a child like this, and when we did BANG, they also did well, and over a period of time they still do well. So this is the trabecular meshwork which is on the tip of the needle. So then the question is it better than a goniotomy? I mean, we've been doing goniotomies, do we really need to do a BANG? So we were very ambitious, and we thought the easiest way to do, since we have so many babies coming, is do a parallel group RCT. Let's have both eyes of the same baby, do goniotomy in one, BANG in the other, and we thought it would be all right, except that when we set out to do it, we wanted stringent criteria, because both of these should be absolutely the same. So we set out to do this, and we realized it was very difficult to get symmetrical primary congenital glaucomas. But we told ourselves that we need a corneal clarity within 1, we need corneal diameter within 1 millimeters, we need IOP within 4 millimeters, and we need cup to disc ratios within 0.2. And it turned out that it was really difficult to get that, and we managed just about 8 children in about a year. But we did a year's follow-up. We did goniotomy in one and BANG in the other, and surprisingly, they did much the same. Both the AGMUs and both the IOP were completely the same in both eyes, which were almost identical at presentation in the same baby. And when we looked at AGMUs and the visual acuity at the end of 1 year, they were also pretty much the same. So the next kid on the block then, Dr. Grover comes up with a GAT, So the more that things come out, the more we want to try it out. And we said, now this is such a good idea. If 90% success with 2 goniotomies, why don't we do it in just 1? So this is really in a PCG, which is why it is a little hazy. So GAT is basically you make a small goniotomy and you use a 5-O-proline. We don't have an illuminated eye track. So that's a 5-O-proline which is going into the Schlemm's canal. The tip has been blunted. There's no extra equipment required. And as you thread it in, so it'll just go in. So as you thread it in, you'll see that pretty much soon you just go in. An average of about 15 to 20 maybe passes into the Schlemm's canal. And then soon you'll see the other end of the proline come out from the other side, and there it is. So this is real time. It's not edited, and actually takes these 2 minutes to just thread it through, and the entire surgery takes 10 minutes. So my anesthetists are annoyed with me because I take 45 minutes to do an EUA and I do 10 minutes to do a surgery. So then it's just stripped across 360 degrees and voila, that's it. 360 degrees of the angle treated. So how does it fit in the real world? Now this baby, for instance, this is how we get them: asymmetric, glaucoma since birth, Peters anomaly in one eye and a PCG in the other, already trabeculotomy done. So left eye we did a trab with trab, we couldn't possibly do angle surgery, but we wondered whether we could do a goniotomy now. So it did work. We did the goniotomy after the trab with trab of the right eye, and it cleared. So this is what our redo goniotomies are. If you treat the rest of the angle, which is untreated after your trab with trab, they do clear, and they actually do well after a while. So this is how the cornea is cleared, and we did a repeat trab in the left eye, the periphery cleared, and we don't have Murli with us, so we make do with a lot of optical iridectomies to visually rehabilitate them, and hopefully we'll get a brave cornea surgeon to do ours as well. So when do you do GAT? When you want to do a little more than a goniotomy, but you don't want to do a CTT. You don't want to open up the sclera and the iris. With 1 year follow-ups, these children do very, very well. So right now, GAT is my go-to angle surgery. I've almost stopped doing goniotomies completely. Interestingly, I just like to share this one baby, acute eye drops. We all get very excited because this is the one PCG which makes us God. Because the mother comes distraught in the emergency that the kid was fine 2 days ago, and look, since 2 days he's got a white cornea, and we say, Tathastu, don't worry, you come to us, you'll be fine. So you have acute eye drops in PCG, you start a dorsalamide, prepare for GA, etc. And then on table, you can see the harbs, and you can very, very hazily see the angle, and there's a bit of you which says, okay, let's avoid the combined trab with trab. Let's see if we can do it. And you have residents saying, no, 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 please don't try, please don't try. Say, okay, let me try it. We can always do it again. So we do that, and it's a little foolhardy, and I've done about 2 of them so far. But you see, you move your gonioscope to an area where you can see it. So I can't see it end on. So I've done it superinasally. I don't usually do the goniotomy there. And then it's a bit of manipulation to put it in. But if you can see your goniotomy and you can see your scleral spur, you know that you're in. And surprisingly, it goes in very smoothly because it's PCG. And there we are, and it came out, and everybody was so, so happy that this happened, thank God, more because we didn't have to do the CTT, and it cleared just as well. So it is a primary trabecular dysgenesis, even if it is acute eye drops, even if the harbs are stretched so much that all that fluid has come in. But if you can treat the angle, you can treat PCG. Sometimes you do it after sad stories when you're scared. This is one of my saddest stories of a baby who was fine after a combined trab with trab, comes back 5 years later with panophthalmitis, and he lost the eye. And the other eye has very raised pressures, and now the father says, do the miracle and save the eye. So I was so scared to go in again, and it was really, really hard. But thankfully, even after a combined trab with trab, interestingly, we did try the GAT, and we said, okay, this was possibly PCG, let's try and do the rest of the angle. So interestingly, since we'd done the combined trab with trab 5 years ago, this, in a minute you'll see that this suture actually came out from the older trabeculotomy site. So there it is. So that's the suture. You can see that thing, that blue thing here. And suddenly we see this entire suture is in the angle, and we realize it had gone almost the whole thing, and it came out through the trabeculotomy side. So some part, so almost the 360 degrees did work, and we managed to have this, and we managed to control his pressures with just that. So there you are. This is the trabeculotomy site of the older CTT, and you just hold it there, and you pull it from this end because it's come out, and there you have it 360. So it's interesting that it comes to your rescue when you really are scared and you don't want to go in because you know the child has lost one eye already. So to summarize, where does angle surgery come into my armamentarium? If you can see the angle, even if it's hazy, yes. Goniotomy and bang doesn't matter. We've published our RCT in ophthalmology glaucoma last year that it didn't matter at all. And when you want a little more than a goniotomy, you do a GAT. But I can share with you now I want a little more than goniotomy for all my babies. And my first go-to is a GAT if I can do it. AB and Turno are expanding to include more and more TM all the time. It's viable, it's safe, it's low cost, and it's worthwhile as a first procedure. And I'd like to acknowledge all my babies and my children for the residents, for the work that they do. And believe me, it's not easy to work with someone crazy as me. Thank you. Thank you, Dr. Manda.
Thank you, Susmita, for extensive coverage on the AB interno technique. Yeah, yeah.
I'm taking the mic because this is my favorite tip to my residents. When you're doing angle surgery, you must not feel tissue. If you feel tissue, you're scratching sclera and you'll have a bleed. If you do not feel tissue and you do it under visualization, the minute you engage the trabecular meshwork, start stripping it. There's no depth at all. The minute it's engaged, whether you're doing a goniotomy, whether you're doing KDB, whether you're doing bang, the minute you see it go and you don't feel it, you're doing it right, and it won't bleed. Initially, yes, because you're scratching sclera. Trabecular meshwork is avascular, sclera is vascular. So you would have a bleed if you're scratching it. But the more you do, the more you'll realize that it goes like hot knife through butter. That's this thing. No, I would say a bleeding is lesser because it would call it. I know, I don't know why they say that, but, well, they do, but I don't think it should bleed. Well, we haven't used KDB, we used a bang, and it was completely the same. And I think it's because when it's elastic, the mechanism in congenital glaucoma is falling back off the TM rather than the cut. So whether you incise it, it falls back. Whether you do a bang, it falls back. So in adults it would, because just an incision would scar down. More towards upwards. Because you don't know where the iris is inserted. So it's always better to be a little higher than at the iris root. So there it's more of a problem.
All right. So we'll may continue the discussion. Probably we'll have some more time. I would like to give a different perspective on the surgical management, where corneal edema doesn't permit just the good view of the angle to the extent that you can do goniotomy scientifically or to your satisfaction. What is the option? Now, a patient presented here with corneal edema bilateral. Simultaneous bilateral surgery was there, we did, but the question comes, what is the best primary surgical treatment? If we see the options available, starting with goniotomy in the year 1938, till date, several surgical techniques came into the literature, and before 1938 there was no surgical treatment, and the ultimate outcome was blindness. Primary combined trabeculotomy, trabeculectomy is a technique which is probably suitable and probably the most important technique in most of the patients we see in India. I learned the technique from my mentor, Professor N.N. Sood, while I was doing my senior residency with him in 87 to 90. Then I moved to L.V. Prasad Eye Institute, where in last 35 years I'll present the outcome of the surgery. A very important surgical technique came into the literature, fiber optic microcatheter trabeculotomy, 360-degree circumferential trabeculotomy. And we recently, in the year 2022, described an improved technique for neonatal onset primary congenital glaucoma, where 360-degree trabeculotomy was combined with the trabeculectomy. Now, if we go into the literature, only a few percentage of patients do this surgery, combined trabeculotomy, trabeculectomy, we call CTT, because of the obvious reason that in some countries, corneal edema is less and probably the disease is not very severe, their goniotomy or external trabeculotomy may be performed. So we'll come to the surgical technique in a composite edited video for 7 minutes. I'll come to it. I'm just saying that this is the deroofing of the Slem's canal, just to show how the Slem's canal looks like in ab externo approach. So I am presenting this video, the outcome of this video. Muralidhar presented this slide. It is a case of infantile onset, I'll say acute hydrops, and you can see how beautifully. Can you improve the sound little bit? You can see the habs dry, and the corneal edema cleared. This child completed about 13 years of follow-up studying. We are looking into the other eye very carefully. There was no glaucoma so far, but long-term follow-up is taken. So the question is, any patient of unilateral onset glaucoma, here is the composite picture, how the corneal edema cleared, and we published this material. Here is the child. A few years ago the child came, and you can see at presentation and 10 years post-operative. But look at the corneal endothelium in the afflicted eye, later eye. It is so poor. In course of time, there may be endothelial failure, and patient may require endothelial surgery in the form of DSEK or DMEK. So I am presenting a video. Watch carefully. Sound is included.
मैं प्रमोद पाटिल, महाराष्ट्र जलगांव से।
मैं पूनम प्रमोद पाटिल हूँ। मेरी डिलीवरी प्रीमैच्योर थी। 10-15 मिनट में पता चल गया क्या हमारा बच्चा ब्लाइंड है। तो मैं इतना रोई थी कि मैं बोली थी मेरे को बच्चा ही नहीं चाहिए।
मैं डॉक्टर के पास में गया और पैडियाट्रिशियन के पास में, बोलता बच्चे का कंडीशन कैसा है? बोलता बच्चा तो ब्लाइंड है, तेरा बच्चा अभी ऑक्सीजन पर है। मैं रो दिया उसके सामने। मैं बोला भाई हमारा जिंदगी क्या होता है, तू इसके बारे में नहीं जान सकता है। नासिक में हमको डॉक्टर अनिल मंडल सर का नाम भी और हैदराबाद अस्पताल का नाम भी पता चल गया था।
मेरे को इन्होंने बोला बच्चे का ऑपरेशन हो जाएगा, तो टेंशन ना ले, ऐसा वैसा वो सब बता दिया। तो यहाँ पे बोल रहे थे मेरे को हैदराबाद एलवी प्रसाद में ऑपरेशन बच्चे का हो जाएगा।
The child was born out of non-consanguineous marriage, and both the parents were blind because of congenital glaucoma. Simultaneous bilateral primary combined trabeculotomy and trabeculectomy was performed on this baby at the age of 3 weeks, when the body weight of the baby was 1200 grams. This is the preoperative appearance of both the eyes, showing megalocornea and corneal edema. What follows now is microsurgery on the right eye. A 1/2 thickness scleral incision is delineated, and a partial thickness scleral flap is then dissected towards the limbus. Surgical landmarks and anatomy of the limbal region is carefully identified, and a 2 by 2 millimeter trabeculectomy block is outlined without penetrating into the anterior chamber. A central radial incision is then made just behind the outer landmark of scleral spur. The objective of this radial incision is to cut the external wall of the Slem's canal and to avoid entering the anterior chamber. The internal arm of the trabeculotome is introduced into the Slem's canal using external parallel arm as a guide. Once 80% of the trabeculotome is within the canal, it is rotated into the anterior chamber and the rotation is continued until 75% of the probe arm length has entered the chamber. In total, approximately 120° of the trabecular meshwork is ruptured by this technique. The trabeculotomy has been completed and now trabeculectomy part of the operation will be performed. The deeper block is excised to complete the trabeculectomy and iridectomy is then made. The scleral flap is then closed with one tenonylon suture at the apex of the triangular scleral flap. The conjunctiva and the tenons capsule are then closed with a running suture of absorbable material using 8-O-vicryl suture. This is the appearance at the conclusion of surgery, and 0.3 ml of dexamethasone injection is given subconjunctivally at the inferior fornix. Today we are seeing that the child's cornea is clearer than preoperative appearance, and by the end of 6 weeks the child will have totally clear cornea and fixation will develop and normal vision development will take place.
कल मेरे बच्चे का ऑपरेशन हो गया। कल डॉक्टर ने पहले बोला था बच्चे का ऑपरेशन करने के लिए थोड़ा सा रिस्क है। ऑपरेशन जब भी बच्चे का हो गया, डॉक्टर हकीम मेरे को खुद बोले कि ऑपरेशन सक्सेसफुल हो गया। हम दोनों इतने खुश हैं क्योंकि मेरा बच्चा देख रहा
और नॉर्मल लाइफ जिएगा, नॉर्मल, और
मेरा बच्चा नॉर्मल लाइफ जिएगा।
The child will be a perfect, healthy human being with good vision, and I hope, I wish this child will become a doctor in future. Compare and contrast the preoperative and the 3 weeks postoperative appearance of the baby. At 6 weeks postoperative, the child had total clearance of corneal edema in both eyes and the bleb appearance was satisfactory. The child is enjoying age-appropriate normal visual acuity in both eyes, and the activity of the child is normal, and the parents are extremely happy with the surgical outcome. Primary combined trabeculotomy and trabeculectomy was very safe and effective in this premature infant with congenital glaucoma, and the child is enjoying age-appropriate normal vision.
दो साल पहले मेरे बच्चे का ऑपरेशन इसी अस्पताल में हमने किया था जिसका नाम स्वर्णव है। आज वो 2 साल का हो गया है। ऑपरेशन इतना सक्सेसफुल रहेगा हमें उम्मीद नहीं थी, पर आज हमारा बच्चा हमारा कैसा सहारा बन रहा है आप भी देख सकते हो। कहीं पे भी मेरा बच्चा हमें हाथ पकड़ के लेके जाता है। ऐसा लगता है ये लकड़ी की जरूरत अभी 1 साल और रहेगी। 1 साल के बाद में अगर वो पूरा समझने लग जाएगा तो हमें ये लकड़ी की भी जरूरत नहीं रहेगी। हमारी लकड़ी हमारा बच्चा ही बन गया है। ऑपरेशन बहुत सक्सेसफुल रहा। आज हमारे बच्चे की हमको बहुत मदद होती है। घर में कोई बर्तन गुम जाता है तो बर्तन हमें ढूंढ के देता है। आज बच्चा देख सकता है तो हमें कितना खुशी होता होगा, आपको हम हमारी खुशी शब्दों में बयां नहीं कर पाएंगे। मैं मेरा पूरा परिवार रेलवे प्रसाद अस्पताल का बहुत बहुत शुक्रगुजार हूँ, विशेषता मंडल सर और उनकी पूरी टीम का बहुत बहुत शुक्रगुजार हूँ।
So what we have developed over a period of 3 decades is an integrated approach, integrating child's medical, surgical, genetic and rehabilitation approach. The improved surgical technique I was talking about will come to the end at the end of my presentation, an edited video of that. So here is a paper published a few years ago, 1128 eyes of 653 consecutive children done over a period of 21 years. Results were published, results are satisfactory. I am not going into the detail. Here is a paper published in 2023, 220 eyes of 121 patients done in the first decade, 1990 to 2000, and all the patients have at least 20 years of follow-up. The results are satisfactory. 46% of the patient gain normal vision, but that is 20/40 or better. A child who completed 27 years of follow-up here. And here is a child, the acute hydrops child, the photograph is here. The child is enjoying good vision with the spectacle correction for myopia. So this is a child who completed 30 years of follow-up. Now, in advanced cases where limbal distortion or distretching is so much, probably goniotomy is contraindicated. Barkan in his original publication said if the corneal diameter is more than 14, probably goniotomy can cause perforation of the globe unless it is done carefully. That's why we used to do combined trabeculotomy, trabeculectomy, avoiding mitomycin C but using implant, ologen implant. So I am coming to a new surgical technique. The
aim of this video is to demonstrate an improved surgical procedure for advanced primary congenital glaucoma. A limbus-based conjunctival flap was raised and the dissection was done in the episcleral plane. Hemostasis was meticulously maintained with the help of bipolar underwater cautery. A 1/2 thickness triangular scleral incision was delineated and the scleral flap was then dissected towards the limbus using a number 15 Bard-Parker blade. A 2x2 mm trabeculectomy block was outlined without penetrating the anterior chamber. A central radial incision was then made just behind the junction of the bluish-grey band and the white band to incise the external wall of the Slem's canal. A drop of viscoelastic material was placed in the opening of the Slem's canal. 2 time forceps were used to grasp the illuminated microcatheter, placing the tip in alignment with the canal, and the device was advanced into the canal. Lighted tip allowed for the surgeon to visualize the cannulation of Slem's canal
for 360 degrees as the catheter was advanced. The catheter was grasped with a forceps when it emerged from the distal end of the canal and was pulled out a little bit. Both the exposed ends of the catheter were pulled in opposite directions using a tangential force like a purse string, thus garroting all 360 degrees of the trabecular meshwork. With the help of venous scissors, the 2 by 2 millimeter trabeculectomy block was removed and an iridectomy was then made. There was minimal bleeding from the chamber angle forming clot over the peripheral iris, and it was removed carefully with the help of Simcoe's irrigation and aspiration cannula. The scleral flap was closed with one tenonylon suture at the apex, and the conjunctivotenon layer was closed in a single layer with a running suture of absorbable material using 8O polygalactin suture. A subconjunctival injection of 0.3 ml of dexamethasone was given in the inferior fornix. Patients with advanced PCG, the collector channels and the aqueous veins needed to carry the aqueous to the episcleral veins are more likely to be anomalous or atrophic. In such a situation, angle surgery, even in the form of circumferential trabeculotomy, is bound to yield suboptimal results. A poorly functioning distal outflow pathway will necessitate an additional surgical step that bypasses it, like trabeculectomy. Hence, we perform IMPACT, that is, illuminated microcatheter passage assisted circumferential trabeculotomy and trabeculectomy in this child. This surgical procedure actually represents a microcatheter-assisted, novel, distinctly advanced, luminous technique, that is, Mandal technique, suitable for advanced primary congenital glaucoma. To the best of my knowledge, this technique has not been reported earlier in the context of the management of primary congenital glaucoma. This technique may represent the next step in the search for the best surgical treatment for management of advanced primary congenital glaucoma. So this microcatheter is in the process of development in the final stage. And probably it will come in the market as a collaboration between L.V. Prasad Eye Institute and Arvind Eye Hospital, Madurai. So probably, I don't know any session is here or not. I'll take 2 minutes to present a video.
मैं प्रमोद पाटिल
while performing circumferential trabeculotomy, breaking of microcatheter is a serious complication. Can we improve the sound? This video highlights the surgical technique of retrieval of torn microcatheter segment on a 4-month-old child with advanced primary congenital glaucoma. What follows now is the surgical technique for exploration of the Slem's canal under a partial thickness triangular. Closure of the superficial scleral flap was performed by applying 3 tenonylon suture, one at the apex and one. Check the accuracy of the dissection. An illuminated microcatheter was introduced into the Slem's canal and then pushed gradually to complete 360-degree trabeculotomy. After traversing 270-degree, the microcatheter broke and the torn microcatheter segment was occupying 270-degree circumference of the Slem's canal. What follows now is the surgical technique demonstrating the retrieval of the retained microcatheter. By a separate incision at the lower temporal quadrant under a partial thickness scleral flap, Slem's canal was explored and the microcatheter was grasped and removed. Closure of the superficial scleral flap was performed by applying 3 tenonylon suture, one at the apex and one on each side of the triangular scleral flap. So I'm just talking about the results. This is the, according to last count over the 35 years, 13 of my operated patients are practicing dentistry. 11 are doctors, of which 8 are postgraduate doctors and 7 PhDs. And several children are doing a job like a teacher, engineer, lawyer, journalist, chartered accountant and self-employed. A child operated at the age of 6th day, completed about 31 years of follow-up, did psychiatry post-graduation and is employed in a medical college in Bombay. A child who was operated at the age of 4 years completed post-graduation in pediatrics, practicing. Here is a child completed MBBS, preparing for postgraduate entrance exam. A child who is now in 4th year, the congenital glaucoma, his congenital glaucoma is very mild and the HAPS is in the periphery. His vision is 20/20 in the afflicted eye. I am encouraging that child to come to ophthalmology and if he can take glaucoma as a subspecialty. A child who was operated at the age of 2 weeks in the year 1993, and you can see here 2022, I attended the marriage ceremony of this girl. She is now, the couple is now parents of 2 children, normal. I just wanted to know any session next. All right, so we'll just. The aim is to train 3H ophthalmology and wisdom. Competent, ingenious, deft and contemplative surgeon is made and not born. I believe that the surgery is the expression of observe many opportunities he made available to me. Professor Sood is a teacher par excellence, an orator of rarity, a writer of an unusual grace, and a complete artist as a surgeon and a deeply religious man. I shall say in no uncertain terms that I owe to Professor Sood all my professional skill, for he is my Guruji with an unflinching stewardship, erudition and expertise, and above all, human qualities as a person. My salutation to Professor N.N. Sood, the noble guru who has opened my eyes, blinded by darkness of ignorance with the collyrium stick of knowledge. To him we pray. Om Ajnanotimidandhasya Gyananjana Shalakaya Chaksurunmilitam Yena Tasmai Sri Gurave Namah. So there is not much time for discussion. We have overshooted the time. This is my mentor with whom I was trained. He passed away in the year 2022, and I last met him in Gurgaon meeting, after the meeting here, 15th February 2020. And 14th February 2022, he passed away. His son was trained with us, Dr. Devendra Sood. He is in Delhi practicing pediatric glaucoma and glaucoma in general. So with this I conclude. I thank all the speakers for a very good presentation, and probably we can come here for a photograph and we should leave the dais for the next session. Outer diameter is about 250 microns. This is in the process of development, and proprietary interest is there in the, they have filed for the intellectual property.